First speaker of part 2, a good friend of mine, Professor Bernard Chern, and his topic is on uterine fibroids, when to operate and when not to operate. This topic I chose from a series of lectures given at APAGE, and this is one of those lectures which I thought was concise, precise, and a very good take-home message. A little about Professor Bernard Chern. Is the head and senior consultant of MIS unit of KK Hospital, Singapore. In 1996, he undergone fellowship with Professor Chris Sutton in UK and with Dr. C.Y. Liu, founding member of APAGE in Tennessee, USA. Associate Professor Chern's professional appointments include the following. He's Chairman, Division of O&G in KK Hospital from 2014 to 2019, which is just stepped down. He was President College of O&G Singapore from 2011 to 2013. He's a member of the Advisory Board and past President of APAGE. He's a board member in Asia Pacific Gynecological Endoscopy Training. He's a Board of Trustee Asia Pacific Representative AAGL from 2014 to 2015. And in 2010, he organized the 11th APAGE Annual Congress in Singapore successfully, followed by equally well-received regional APAGE meetings in Singapore annually. Indeed, he has contributed tremendously to the advancement of MIS in Asia. Now, without further ado, I invite Professor Bernard Chern, past president of APAGE, and his topic is uterine fibroids, when to operate and when not to operate. Over to you, Bernard.
Right. Thank you, KY, for your very kind introductions. Okay, so today my topic is about fibroids and fertility. The question here we are asking ourselves is that when should we operate for women who have fibroids and are keen to conceive? So my talk today will touch on the classification of fibroids, which I think is very important because that should be the basis how we're going to compare outcomes in various clinical trials. And I also touch on how does the various possible mechanisms that fibroids may affect the fertility potentials of a woman, and of course to examine the current data that's available to us, especially the various clinical pregnancy outcomes in women who are suffering from fibroids. Then, of course, we have to discuss briefly the various management of fibroids when women are suffering or having fibroids and they desire to have more pregnancies, the various surgical options, and of course the alternatives as well. So I'm going to run through this classification. This is a FIGO classifications of fibroids locations. And of course, we are familiar that for type 0, type 1, they are essentially submucous fibroid. Type 2 are submucous fibroid, but there's a significant proportion in the intramural locations. Then type 3, type 4, and type 5 basically are located in the myometrium, all right? And the type 5 has a subserous extension. So the way that fibroids causes fertility issues are not fully understood. But in some instances, it is pretty obvious because huge fibroids, especially those located very close to the fallopian tube, can cause obstructions to the fallopian tube and thereby causing a fertility issue. And some authors believe that the presence of fibroids may alter the uterine contractions and the uterine peristalsis and therefore affecting implantation. And some authors feel that the changes in the implantation factors may affect the embryo implantation as well. So let's take a look at some of the data that's currently available. Elizabeth Prentice publishes a paper in Fertility and Sterility quite a few years ago examining the issues of fibroids on fertility. I think it offers a very good insight into some of the problems that we face as a clinician every day. It is a systematic review with meta-analysis looking at 23 studies in total But unfortunately, there's only one randomized control trial. If you take a look at the data, if you just look at the submucous fibroid portion versus those women with no fibroids, it is quite clear there is significant decrease in the patient's implantation, clinical pregnancy rate, as well as live birth rates. And this is also associated with the increase in miscarriage risk. And the magnitude of reduction, we are looking at 60 to 80% reduction. And this is, I believe, most of us, we encounter this during our day-to-day clinical practice. And women with significant submucous fibroid often come to us, not just with recurrent miscarriages, unable to get pregnant, and sometimes associated with abnormal lie in subsequent pregnancy and so on. But if you look at the data on the intramural fibroid versus women with no fibroids, it appears to have a reduced implantation rate for those women with intramural fibroid associated with a lower live birth rate as well. And similarly, this is associated with the increase in miscarriage rate. But if you tease out those studies whereby hysteroscopy has been performed, then you find that women with intramural fibroid, they do suffer from a reduced implantation, but there's no apparent effect on the clinical pregnancy rate or a live birth rate. So it is important to have proper evaluations of the uterine cavity when you are conducting a trial comparing the various styles of fibroids on fertility. So the question is that if a woman do have fibroids and suffer from infertility, does surgery help them? So it is quite clear that if you have submucous fibroid or intracavitary fibroid distorting the uterine cavities and shape, removal is generally recommended because it is believed that these fibroids causes pregnancy issue and removal will enhance their fertility. If you look at the same study, comparing women with submucous fibroid surgery versus no surgery, you find that the pregnancy rate is almost double after the removal of submucous fibroid. What about women with subserous fibroid? I think most of us will believe that there's no evidence that removing subserosa fibroids will improve fertility, pregnancy rate, or other obstetric outcomes. Of course, we do know that large fibroids in pregnancy can potentially undergo degeneration, etc., and causing pain. But itself is generally not believed to be a factor for infertility. But however, you may have to consider surgery if a hysterosalpingogram demonstrated occlusions of the tube is occurring because of the subserous fibroid. So the next questions are the intramural fibroid. I think this is the most controversial, especially the type 3 fibroids. Now, we look at this paper, which again is a systematic review and meta-analysis published by Sankara from the guys at St. Thomas Hospital, NHS. This analysis included 90 observational studies comprising 6,000 over IVF cycles. And they found that patients with fibroids, non-cavity distorting intramural fibroid is associated with the reductions of live birth rate by about 20%. And they are looking at a group of patients who are undergoing IVF treatments. And if they do have fibroids, they find that there's a reductions in the success of your IVF cycles. Then the next paper published by Lian from the Shanghai University examined the effect of type 3 fibroids on IVF again. This is a retrospective study. And they found that if there is an intramural fibroid of larger than 2 centimeters, the patient will have a lower chance of having a successful implantation, a lower chance of having a clinical pregnancy, and a lower live birth rate. but there's no associated increase in the miscarriage rate. And this paper again examined the effect of a fibroid size on the mechanism of a fibroid causing fertility chances. And it reported that the live birth rate in women who have 2 fibroids or more, or if the fibroid size is more than 3 centimeters, the patient will have a reduced chance of a successful pregnancy. But the problem is that if you do look at the various data that's available to us, they are derived from studies, mostly heterogeneous. The numbers from some of these studies are very small and underpowered, and most are descriptive studies. And very often, the intra-cavity assessments will not perform. Most of the fibroid locations were reported based on the ultrasound examination. And we all know that ultrasound may not accurately report and localize some of the fibroids, especially with the submucous extension. Proper diagnosis with hysteroscopy, MRI, and the saline sonographies are often important, and because this is the way that you actually would tease out the submucous fibroid from the pure intramural fibroid, and you can more meaningfully compare the obstetric outcome and the pregnancy outcome. So, even if you do believe some of the data that's currently present, that intramural fibroids can affect their pregnancy, the next question is that by performing surgery, or in this case, we are looking at performing myomectomy, reverse that trend. Can surgery improve their pregnancy after they have gone through it? This is a single center studies in Cleveland against the retrospective studies over a long period of time, 10 years. And they found that the patients, whether they have fibroids in situ, nothing done, or patients who have no fibroids, or patients who have fibroids have undergone myomectomy, the differences in their live birth performance is not significantly different. Those who had myomectomy appear to have a faster time to pregnancy, but at the end of the day, there were no significant difference in their cumulative live birth rate. So going back to Elizabeth and Pritch's paper, again, she has drawn the same conclusions that in patients with intramural fibroid, whether surgery has been performed or not, there were no significant difference in the ongoing pregnancy or the live birth rate. So that basically from these 2 papers, more or less, we can tell our patients, even with the performed surgery, we cannot guarantee that their fertility will be enhanced. But we know one thing for sure: performing surgery on the womb, removing fibroids, definitely carry with itself significant surgical morbidity. We're all familiar with the postoperative adhesion formation. Only can give rise to pain, it can cause obstruction to the fallopian tube, and more fearful, of course, is the risk of uterine rupture. Because when the cavity is breached, there's a risk that the uterine scar will give way. These are some examples, some of the papers were showing the chances of patient developing postoperative adhesions after myomectomy, and we are easily looking at 50 to 70% chance of adhesion formation. And of course, associated with that, the subsequent possible complications such as colic or even intestinal obstruction. Then if you do examine the risk of uterine rupture, and we can conclude that the risk of a woman who had myomectomy before has a chance of her uterus rupturing of 1.5% even before the onset of labor, and intrapartum, the risk again is 0.5%. And if you add these 2 together, that means that the patient will have to face a risk of uterine rupture either antenatally or intrapartumly, up to 2 to 3% possibility. And that's the reason why it is not surprised that ASRM has made very few conclusive recommendations on the management of fibroids in patients relating to fertility. If you look at it, under grade B recommendation, essentially it says that submucous fibroid should be removed by hysteroscopic myomectomy, and it shows that that will improve clinical pregnancy rate. But if you look at others, in terms of the possibility of intramural fibroid affecting pregnancy, surgery removing intramural fibroid to enhance pregnancy, did not receive any significant data support or evidence support. So then, if you think that a submucous fibroid 0, 1 or type 2 surgery is useful, then what are the challenges we face? The surgical approach to this group of fibroid logically should be performed via hysteroscope, because that will protect the myometrium without causing a hole in the myometrium and therefore the risk of uterine rupture. But of course, if we have fibroids which are larger, and especially the type 2 to type 5 extending to the subserous surface, and this fibroid perhaps may have to be removed laparoscopically or via open myomectomy. If you do compare these two, especially if you are just looking at type 0 to type 2 fibroid, I often ask myself, which is the better approach, especially if they are larger? The smaller one is quite clear if we remove it from below, hysteroscopically. But the larger one, what about those who are 4 centimeter, 5 centimeter and above? And especially they are type 2, perhaps only part of it is in the submucous cavity, in the submucous location, and the bulk of it is in the myometrium. Which is the better approach? If you look at it, hysteroscopic myomectomy, advantage, as I mentioned, uterine cavity not reached, less damage to the integrity and the strength of the uterine musculature, and you don't have to worry so much about uterine rupture. But if you have a large fibroid, when you resect a large submucous fibroid, 4 centimeter, 5 centimeter, you can imagine large amount of endometrium will be removed as well. And then what are you faced with? So yes, on one hand, we know that by removing the submucous fibroid will improve the fertility. But now you are to face another challenge then. What about the intrauterine adhesion formation? Asherman syndrome. So on one hand, you think that removing the fibroid may improve fertility because improve implantation, etc. But at the same time, if you end up with the intrauterine adhesion formation, especially if you're talking about larger fibroid, you are going to neutralize all the benefit of surgery. Laparoscopic myomectomy, better, right? In that case, let's say a 5 centimeter type 5 fibroid, you were able to protect the endometrial lining. You're able to preserve that. Therefore, there will be less problem of Asherman syndromes, intrauterine adhesion formation. But then you are trading in for what? You are trading for a weakened uterine musculature and an increased risk of uterine rupture when she does get pregnant. So in conclusion, among the various locations, intramural fibroid, it is the most challenging. Submucous fibroid is clearer. Removal does improve fertility outcome. Subserous fibroid, no, it's quite clear as well. But intramural fibroid, the evidence that we have thus far is possibly associated with lower fertility outcome. The numbers, the size, the exact location may play a role. Unfortunately, the existing studies that this evidence would derive perhaps have included some submucous fibroid as well, as their location are often just ascertained based on transvaginal ultrasound. And very often, HSG hysteroscopy would not perform. And the next questions, on the next challenge we face is that there is no level 1 evidence that if you to perform surgery will improve fertility. But for sure, we know that surgery is associated with adverse fertility outcome, such as adhesions formation, uterine rupture, and so on. So, in that case, shall we operate? Consider surgery if the location is blocking the ostia, obstructing your oocyte pickup, or if you have patients who are symptomatic, who have bleeding, menorrhagia, etc. I think the options for non-surgery will be lesser. Essentially, more studies are required, and we need more precise fibroid locations and definition, and they may require MRI or hysteroscopy for better conducted studies. And hopefully in the future, we have more evidence that we can work on to make more clinical, more suitable clinical recommendations to our patients. With that, thank you.